Hi, my name's Aliane Erickson, and I'm the Division Director for Children, Youth, and Families in Fairfax County. I'm really excited to be sharing with you today information about a new service model that we have implemented here in Fairfax County. As many of you know who work in the child welfare space, a large proportion of why we get involved with families is due to parent and caregiver substance use issues that can often place their children at risk of harm. Maltreated children of substance-using parents often remain in state custody longer and experience poorer outcomes than other children. However, as we all know, with adequate supports and timely access to appropriate services, many children can stay safely with their substance-using parent, and every attempt should be made to do so, as separating a parent from a child is a traumatic event that can have lifelong consequences. With that understanding, in Fairfax, we really wanted to partner and provide support to families facing these complex issues in a much more holistic and compassionate manner. We also understand that many of our child welfare practitioners are not as educated in how to best intervene and partner with these families. That is why in Fairfax County, we decided to embed a parent support specialist into our family engagement unit to collaborate early on with the Child Protective Services practitioner. The hope is to engage that family member who has a known history of substance use as early as possible. We believe that this is a much more effective way of working with our families, as well as providing consultation and much needed education to our child welfare practitioners. It's really important to note that we by no means created this model. And there are many great peer support programs that work in the child welfare realm that are proving to have really great outcomes. When we started down this journey 4 years ago, we came across an evidence-based program out of Kentucky called the Sobriety Treatment and Recovery Teams Program, the START program. Why recreate the wheel when we didn't have to do so? Since we were not able to provide the resources necessary to implement the START program to fidelity, we were able to incorporate some of its important tenets, which we wanted to model here in Fairfax. We felt strongly that starting somewhere was way better than not starting at all. The START program operates within the child welfare setting and relies on well-trained child protective social services workers, peer recovery specialists, and emphasizes a strong collaboration with the substance use treatment providers and human services agencies to effectively engage parents and connect them to substance use treatment services in less than 30 days from the first meaningful contact with that family. With START, speed is a factor to their success. We know that crisis can be a great catalyst for change. Some of the key strategies for START is peer support, quick access to treatment services, shared goals and decisions regarding addiction treatment, specialized training, smaller caseloads, and they work with both mothers and fathers. So how did we operationalize this in Fairfax? Our parent support specialist is housed in our family engagement program under our parent support services umbrella. Our parent support specialist is someone with lived experience and can really connect with our parents or caregivers on a totally different level. He is there to provide support and help clients to reconnect with the world and themselves in a totally different way. The service is 100% voluntary, and we are really intentional in ensuring that the parent support specialist is not seen as another arm of child protective services. The CPS specialists and our parent support specialists do not conduct joint home visits during the CPS assessment investigation phase. Parents are assured that they have the right to hire or fire the parent support specialist at any time. Receiving this service cannot be used as a condition for reunification or prevention of separation. When CPS identifies eligible parents for our program, a referral is made within 10 days of the first meaningful contact to confirm a parent's eligibility. Individual peer support services are then offered to the parents by Child Protective Services, at which time permission must be granted by the parents for our parent support specialists to reach and begin the engagement process. While our parent support specialist collaborates directly with our primary child welfare specialist, the details of his interactions and conversations with the parents are not shared. Only general information about a parent's level of engagement in the program are shared. So for instance, what stage of change is that parent in? This is really intentional and important to note that this service is here to support the parent or caregiver in their own recovery process, and they have someone who they can relate to and connect with that is separate from the child welfare intervention. So let me talk a little bit more about some of the details in the program. One of the exciting programs that we've implemented is the self-management and recovery training, SMART meetings, which are facilitated by our parent support specialists. This is a support group that provides tools on coping with urges, managing stress, and enhancing motivation. Consultation and training of all of our child welfare staff is key, as well as effective collaboration and breaking down the barriers to service delivery so that we can connect our clients as soon as possible to a recovery network. And last but not least, we're really excited about a new program called Pathway to Healing Support Groups, which is really for families and friends of people suffering from substance abuse issues. And those will begin in May 2021. So let me talk to you a little bit about some of the barriers we've identified in trying to implement our program. Mistrust of the government, especially by communities of color, has been a big barrier. Our systems have historically not effectively served people of color and have even caused harm. This is an issue we are actively working on to overcome as we continue to evolve in our ability to apply an equity lens to our work with children and families of color. The parent support program is really still in its infancy. We only have one position, but we are actively providing our managers, supervisors, and frontline staff training opportunities to not only learn about the peer support and the associated benefits, but to also improve their own knowledge, skills, and abilities to effectively intervene with families challenged with substance use. We serve a really diverse community in Fairfax in terms of race, ethnicity, culture, and language, and we will need to grow in order to ensure our ability to meet the unique needs of our families. So now that I've talked a little bit about the barriers, let me shed light on some key factors that we've identified to successful implementation. Obtaining buy-in from the top is key. We were persistent and patient. Involving key stakeholders, representatives from our child welfare programs, inviting them to join our multidisciplinary implementation team, and involving them in decision-making process was also key. Consulting and collaborating with our local CSBs, peer support and assessment teams, to share resources and to learn from each other. Working closely with our quality assurance team for the development of measures and data collection. In Fairfax, we were lucky enough to get buy-in from the top. We were able to strengthen and realign our resources to use general funds to create this one position. Since we're a really data-driven agency, we're collecting quite a bit of data in order to assess service effectiveness. Some of the key measures include, and are not limited to, timely access to treatment and other substance use related services, improved engagement and retention in substance use treatment, increased child welfare staff knowledge, and improved skills and abilities. In terms of some interim outcomes, we would really like to see enhancements of protective factors in the following areas: family functioning and resiliency, social emotional support, concrete supports, nurturing and attachment, and children's social emotional competence. Some of the longer term outcomes we're hoping to measure is successful reunification with biological parents after informal separation, obviously reduced days of children being in care, and a reduction in reoccurrence of treatment. And last but not least, sobriety at case closure. We've had some really great feedback from our practitioners thus far. Our primary specialists assigned to those families really reported that parent support services were absolutely instrumental in helping the parents move quickly from the pre-contemplation stage of change to eventually taking action around their substance use. They were successful because engagement occurred very early in the life of those cases and because services were provided, most importantly, without judgment. So I want to challenge my colleagues in the child welfare space to adopt some form of peer recovery in their programming. We can and should pivot to do our work differently in child welfare. And let's change the way we engage with our clients, our colleagues, and our larger system.
Hi, how's it going? My name is Aditya Narayan, and I am an AmeriCorps Vista working in the Virginia Department of Social Services on substance use disorder efforts. Today, I'm going to be talking to you about peers and people with lived experience and the value that they provide to policy and practice making initiatives in the recovery space. So, in terms of what we'll be talking about today, just to give you a brief overview, we're going to start really with what peers are. We're going to discuss a definition of peers, provide a little bit of historical context to help you understand how peers and this idea of incorporating lived experience into health, into policies, into clinical spaces has evolved over time. We'll discuss a little bit about the efficacy of peers, as we know that that's incredibly critical in order to generate buy-in from a variety of different stakeholders. And we'll discuss how peers provide a unique sense of cultural humility, as well as an economic effectiveness, which can make incorporating them into your spaces a relatively easy sell. From there, we'll discuss how peer recovery functions in the substance use disorder space. We'll talk about peers in clinical and policy-making spaces, the intersection of peers and parenthood as an experience. We'll talk about barriers to peer utilization, best practices for the integration of peers, and we'll conclude with some resources and various other takeaways that you can hopefully bring to your setting of work. So first, let's start with some definitions of what it means to be a peer and what it means to have different types of certifications and levels of lived experience and how that actually applies to the different types of clinical settings a peer might work in or policymaking settings and so on. So probably the most fundamental understanding of a peer is what we might call a natural peer supporter. That is an individual who has some sort of organic experience which aligns with another individual. And through that commonality, they're able to generate rapport. And there's a lot of different terms that you might see for peers. And I think that's why it's so important for me to sort of level set and describe how we will be discussing peers. But you might see terms such as peer specialists, recovery coaches, peer counselors, and so on. SAMHSA defines a peer recovery specialist then in a step above what it means to just be a natural peer supporter as an individual who uses their lived experience of recovery from mental illness or substance use disorder, in addition with skills learned in formal training to deliver services in behavioral health settings to promote mind-body recovery and resilience. Now, in Virginia, peer recovery specialists are those who have completed the 72-hour training program offered by the Department of Behavioral Health and Developmental Services, which I'll abbreviate as DBHDS. Now, this training does not necessarily provide you a certification at the end of it. In order to be trained and be a Medicaid billable certified peer recovery specialist, it is necessary to accumulate 500 hours of service following this 72-hour training. I'm referring specifically to Virginia here, but there is also a national peer recovery certification process that someone might go through in order to have a more widely applicable certificate. So let's talk about the history of peers and really how the current movement towards engagement of those with lived experience in recovery for the purpose of supporting others with those same experiences really developed. So it dates back a couple hundred years, actually. So near the end of the 18th century, there was a superintendent of a hospital in France who really pushed for the hiring of people who had had previous healthcare issues to serve as employees in his hospital because he acknowledged that they were perhaps more empathetic, that they understood the struggles of navigating the healthcare system, and so on and so forth. And that movement actually led to a rather incredible shift in the consciousness in that hospital setting and in the local community, as there was a push to do away with forced mental health treatment, for example, and shackles that were placed upon, literal shackles that were placed upon those who experienced mental health issues. This empowerment of those with mental health issues became a somewhat larger and larger force within the common landscape of healthcare. And this idea of peer support then surfaced again multiple times over the years, and it peaked really in the 1960s. And this was really because of some tailwinds that were coming in America due to the civil rights movements and other sorts of initiatives designed to provide agency to traditionally marginalized populations. Professionals in community mental health settings were actually among the first to advocate for the integration of peers into primary care practices. Now, community mental health essentially focuses on employing non-professional or natural peers, as I described previously, into the work that is going on in a public health context in order to meet the specific needs of a particular community and perhaps to develop or implement and evaluate different sorts of health interventions. So now we hit the 1970s and we have what's called the mental health consumer movement, as it's been described in the literature. Now, this is a social movement essentially that empowered former mental health service users to organize, to unionize, to again seek empowerment, and to advocate on behalf of compassionate mental health policies and practices for others who have gone through or are currently going through similar experiences. At the same time, the US, as with many other countries in the world, began to what's called deinstitutionalize, moving mental health from the institutional or hospital settings out into the community, out into the clinics, and away from just the bed. This is reflected in the research as well. In 1991, you have the first report of a peer healthcare delivery model that actually makes its way into the medical literature and is published. And peer support from then really began to explode. And you start to see that it is being applied to chronic disease management, screenings and prevention for different types of stigmatized and marginalized communities, such as HIV or AIDS, or in specific infectious diseases, as well as in maternal and child health. For example, breastfeeding, nutrition, postpartum depression, and really servicing the needs of these communities who have very specific and tangible needs that are very difficult to meet by somebody who does not have a shared lived experience. So let's take a step back and actually ask this fundamental question of, do people care about having other people around them with the shared lived experience? Is this actually going to impact the care that people receive or their desire to seek out healthcare or certain providers over others, for example? And the answer is a pretty resounding yes. So of those with healthcare issues, roughly 1 in 5 internet users have gone online at some point to find others experiencing health concerns similar to their own. A clear majority, about 59% of adults, based on a 2010 Pew Research poll, found that they favored friends, family, and fellow patients when they needed emotional support in dealing with any particular health issue that they were experiencing. Consider that in terms of practical day-to-day advice for coping with complex health issues, about 50%, again, of patients seek out not professionals necessarily or other sorts of literature resources. They seek out people who have gone through and understand what it is that they're going through, that is fellow patients, friends, and family. And so when you want to boil it down, ultimately, the literature shares that there are essentially 3 unique contributing factors that define peer support as different from the support that a physician or a care provider who has never experienced a particular health issue can provide. So first, it's the aspect of self-disclosure. A peer who discloses that they have gone through a particular concern, for example, substance use disorder, which is of course an incredibly marginalized and stigmatized disease, can improve the self-efficacy and belief in one's own ability to achieve success in other individuals. Essentially, if I'm a patient, I see that somebody is able to achieve success or their own goals, whatever they may be, despite similar challenges to what I went through. And that allows me to have a role model of sorts and believe in my own path to recovery. Second, it's the fact that individuals with certain experiences are able to share those experiences with others. And while I know that this is a very general statement, consider the day-to-day challenges of living under the burden of stigma. Perhaps it's homelessness, perhaps it's food insecurity, housing insecurity, and so on. That is not something that can be understood simply from an outsider or third party or academic perspective. It is something that mandates a lived experience in order to create the advice and provide that advice to others who are going through a similar experience. And finally, it's the fact that peers provide a very unique empathy. It's a conditional regard for other individuals defined by a peer's ability to read the status, the emotions, the health state, the needs, wants, and barriers of others who hold similar experiences. And we know that ultimately this manifests as better care and greater support structures and scaffolding for individuals who experience substance use disorder. So we've reviewed the evidence on really what it is that makes peers so effective at what they do. That is that their lived experience can be leveraged to serve others in incredibly unique ways. If we're just talking about the efficacy of peers based on the literature, there is support for that, of course, as well. If individuals broadly spend even just 6 aggregate hours per year with professionals, physicians, and so on, that still leaves about 8,700 hours per year that they are alone. And we know that health is not necessarily based in hospitals. It's based in where we're born, grow, eat, live, work, play, and pray. And so in accordance with that fact, we need to acknowledge that it is necessary to provide continuous support and reinforcement for the process of recovery outside of just the clinical setting. Research shows that social support has direct impacts on objective health metrics, patient self-efficacy, and in addressing the various social determinants of health. By contrast, social isolation is often intrinsic to psychopathology, which we've seen during the ongoing coronavirus pandemic, and it suggests that frequent, affirming, and positive contact from a peer, supporter, family, or friend, as I mentioned earlier, can make the difference in treating mental health issues. Several studies really indicate that peer-delivered services create superior outcomes in terms of engagement in individuals who may be considered traditionally difficult to reach, through no fault of their own, of course, reduced rates of hospitalization in patient populations, decreased substance use among those with co-occurring or comorbid substance use disorders, and so on. A review of evidence document will be available on the associated website with this video. Please feel free to take a look at that and further establish your foundation of understanding of the efficacy of peer support mechanisms. Now, the concept I specifically want to unpack is cultural humility. So cultural humility can be very broadly defined as the ability to remain open to aspects of cultural identity in others that you may not be familiar with. Now, cultural humility can be distinguished from cultural competence, and I want to make that distinction quite clear. While cultural competence may be a term that you've heard before, I believe that it focuses on really trying to boil down people's lived experience into a series of checkboxes. Ask yourself this question: is it possible to be competent in another person's culture, in another person's lived experience? Can you simply treat others who describe their life and their story and the settings in which they were raised and currently exist as merely unreliable narrators of their own experience who only exist as a series of checkboxes? Because I don't personally think so. I think it's critical to recognize that differences in language, age, cultural norms, socioeconomic status, political and religious leanings, sexual orientation, and life experience all represent this full spectrum of diversity. And all of these diversity characteristics add additional dimensions and complications and dynamics to cross-cultural interactions. I believe that peer recovery specialists are one step towards bridging that gap. And we know that this is actually effective. In a 2010 study, peer-based culturally responsive care for African American and Latinx patients led to dramatic improvements in patient perceptions of their care, increased self-efficacy, and decreased psychotic symptoms. Cultural humility then represents an opportunity to integrate those who can have and offer a unique understanding of their own and others' lived experience to bridge the gap when we are not able to. So peers can bridge that gap, as I mentioned, but we also have to consider this from an administrative standpoint. What is the cost of integrating peer support? What does it mean to integrate these new systems of care, and what are the implications for our healthcare systems at large? I know that's a pressing question whenever we consider what it means to craft public health interventions, but I think what I'll share with you is actually quite positive in nature. So based on a seminal study conducted in 2006 with Georgia's Department of Behavioral Health and Developmental Disabilities, there was a randomized controlled trial which compared service users who received care with certified peer recovery specialists as part of their treatment versus those who don't. Those who did not use certified peer recovery specialists in their treatment had an average cost of about $6,491 per day for their treatment. Compare that to those who did have CPRSs integrated into their treatment, and the number is a staggering $997. That's an average cost savings of about $5,500 per person for the state. And so, with this data from SAMHSA, in addition to other resources which we'll be able to provide you on the associated website, hopefully you can generate additional buy-in in your colleagues and in various other stakeholders in the health system that you occupy. So as we presented from the evidence, peer recovery is an incredibly viable pathway to improving the services that are delivered in the mental health care space. We've already seen that peer support is an incredibly key component of existing addiction treatment and recovery programs. Medication-assisted treatment programs, therapeutic communities such as recovery housing, for example, leverage peers in unique ways to benefit those that they serve. And 12-step programs are very much built on this concept of working in a peer space wherein individuals have the opportunity to self-disclose, share their strengths, and support others who are experiencing similar challenges. This community reinforcement approach has demonstrated the important role that social relationships have in maintaining recovery, which is ultimately the foundation for the peer relationship. So peers, we understand, can operate in a variety of different healthcare settings. Peer support is gaining recognition in almost every sector of health and healthcare. Health researchers are continuously building the evidence base for peer support for a variety of disease conditions, populations, and settings, even though that this is a relatively nascent space that's only existed for about 20 to 30 years in terms of the literature base. Health providers are seeing the benefits of peer support on their medical practices, particularly when it comes to patient satisfaction and that elusive metric of patient outcomes. Employers and health insurance companies are increasingly implementing peer support programs for their employees and for their patients, respectively, to promote workplace well-being, to increase productivity, to promote health maintenance in patient populations, and to overall reduce costs. It's also possible to embed peers in a variety of other health service organizations, such as community service boards, federally qualified health centers, and managed care organizations. So let's consider this from the perspective of the decision makers. Policymakers broadly see peer support as an effective strategy for community outreach, quality improvement, increasing access to primary care, and reducing health disparities. So why don't we take the next step and begin to talk about how we can incorporate peers into policymaking settings? Virginia has taken steps in the right direction on this front, with Virginia's Medicaid Member Advisory Committee, comprised of those who utilize the service, who are then able to offer their unique experiences to improving the program overall. The Virginia Department of Social Services Youth Advisory Group, called Speak Out, or Strong, Positive, Educated Advocates Keen on Understanding the Truth, also provides a youth perspective and their own lived experience, again, leveraged towards improving the overall function of the DSS and the benefits programs that it runs. Consider other states, for example, the National Harm Reductions Partnership with New York City in the incorporation of drug users and those who have lived experience in recovery into policymaking settings where they can inform practices about MAT, that is medication-assisted treatment, harm reduction programs, and so on. There's a lot that Virginia as a state can learn, and of course, progressive steps that we can take forward as a country through collaborations as well. So one intersection that I particularly want to explore in terms of lived experiences is one that is incredibly relevant to the Department of Social Services itself, and that is this intersection between parenting and substance use disorder. Pregnant and parenting people are a unique population disproportionately affected by substance use disorder and accordingly require tailored services. In an effort to potentially provide a one-size-fits-all approach, you end up with a one-size-fits-none. Gender-specific treatment options employing peers who are also mothers in recovery can be that critical link supporting this population through a trauma-informed lens while utilizing a whole person-centered approach. Research suggests a significant difference in participant outcomes between a trained PRS who is a mother in recovery compared to a woman who is a peer through lived experience with pregnancy or parenting, but who does not have lived experience with substance use disorder. Consider some pilot programs. For example, in Illinois, they implemented a pilot program utilizing a dual certification process for doulas and certified peer recovery specialists. The Virginia Department of Behavioral Health and Developmental Services training is leading the way in certifying and training PRSs, but there is opportunities to grow this specialization around prenatal and parenting people as PRSs to serve the unique needs of this high-risk, marginalized population. Other states such as Oregon, Rhode Island, Massachusetts, and Illinois, as I mentioned, have developed additional training components as supplemental materials to coincide within their PRS training manuals by offering additional subpopulation certification competencies, which can span veteranship, family support, and forensic PRS certifications. Essentially, women disproportionately suffer the impact of stigma against the substance user population as we provide a moralizing gaze to their condition. And in accordance with that, we require a PRS which is able to serve the unique needs of these populations. So to this point in time, we've discussed the potential value out of peers, the unique strengths that they bring to the table in terms of their cost effectiveness, in terms of the cultural humility that they can provide and the gap that they can bridge in those types of cross-cultural interactions and so on. But we understand also that it is necessary to overcome a number of administrative hurdles and different types of issues when you're trying to make that jump to actually incorporating peers into your policymaking setting, practice, into your clinical setting, and so on. And so from the DSS, we want to share with you some of the best practices that we have compiled in our own journey to incorporate peers into our work. And so it really starts with incorporating administrative and other stakeholders as early in the process as possible. Provide them with the benefits of peers and ensure that you can generate buy-in while aligning multiple different, potentially disparate stakeholders in such a way that you understand the unique needs, drivers, and barriers from all of the different people sitting at the table. Generate a clear description of the role of peers in your organization and make sure that it is shaped by all of those key stakeholders. You again want to create alignment, and that's honestly more of the battle than anything beyond that. Create roles and responsibilities for peers which are unique to their skill set. Now consider also what their unique lived experiences might be. We described previously the value of having peers who have experience with pregnancy or parenting. In a similar way, allow the peers' experience to shine through rather than simply providing them with a different type of existing role that is not tailored to their specific situation. You don't want to hire a peer and simply put them as a desk worker because they're not using their unique experiences. Hire peers in groups if you can. This can facilitate onboarding and allow for the sharing of best practices among that peer population so that they can share their gripes and their challenges and their ideas with each other such that it is more effective and possible then to create a step forward within the practice. Provide peer-specific training then around leveraging their personal stories to serve others, how to set boundaries, self-care, how to navigate whatever your institution might be, and ensure that you're not just throwing new peers out into the deep end. Ultimately, it really takes consistent support and scaffolding, as well as champions, those who will lift up the experiences of peers as individuals and to defend them from potential attacks at a systemic level. This may require group-wide trainings to mitigate bias, and it may require restructuring of company policy, but ultimately we believe that this is a step in the right direction. So we've discussed the history of peers and how they came to be, the definition of what it means to be a peer, and the efficacy of peers in different policy and practice-making settings. We've talked also about how peers can best be incorporated into your own practice or your own institution. And we also know the value of having resources available, people who can support you in providing technical assistance or simply a model to base your own work off of. There are organizations I'd love to share, for example, Vocal, Virginia Peers speaking up for mental health recovery. You could join the Recovery Blast listserv that's run by the Department of Behavioral Health and Developmental Services. You can reach out to the Virginia PRS network for tips and tricks and different types of support mechanisms. And of course, please feel free to reach out to us at the Virginia Department of Social Services, and we can provide you with additional types of information, support, resources, and anything else. Ultimately, we believe that peers are, and those, of course, with lived experience, are the most important yet least consulted stakeholders in the mental health care service industry. And we want you to join us in taking a step forward towards a more progressive, a more equitable, and more ethically aligned mental health care delivery system, which serves the needs of the most vulnerable and marginalized among us. Thank you.